Good morning again. My name is Doranira Kaburia from Kenyatta National Hospital. We're about to start our webinar. So a quick round of introduction. Dr. Shazim, Salimia wa Kenya.
Hello, everyone. Thank you, Dr. Thuran.
Dr. Wanjiru Korir.
Good morning, colleagues.
Thank you so much. Dr. Kiomo.
Good morning, everyone.
Thank you so much. Dr. Oweru.
Good morning, everyone.
Very good. Nento.
Good morning, everyone.
Very good. Our boss, Lois.
Oh, I can't start the video. Good morning, everyone. Many thanks for joining us this very cold morning if you're in Nairobi. I wonder what it is like in other places, but it's very good to have you on board. Today, we do the last series of the oxygen therapy session, and we'll be looking at a number of things. One, we'll have a case presented, and we have with us Dr. Kioma and Dr. Mugera, who will help us discuss that case so that we learn from it. Then we look at issues around home oxygen therapy. You realize there's been a lot of concern around issues of home oxygen therapy, and Dr. Oweru is on board to take us through how to, when to, and if to consider home oxygen therapy. So thank you all for joining. We're looking forward to a very exciting session. So we'll go ahead and start with Dr. Shazim. Doc, if you're able to share your screen, and then you can go ahead with the presentation. Dr. Shazim will present a case from CGTRH.
Thank you. Thank you so much, Dr. Acheng. Yes, I'll go ahead and start sharing my screen. And can everybody see the screen?
Yes, we can see your screen. Maybe you could put it on slideshow if possible.
Yes, there we go.
Excellent.
Okay, so we will be discussing one of the cases we managed at our COVID-19 ICU at Coast General Teaching and Referral Hospital. The outline includes talking about oxygen therapy in COVID, escalation to non-invasive ventilation. And in this particular case, we will talk about the patient and the disease outcome. So this was a very interesting case we had. We had a 67-year-old Caucasian male, WUM. We will call him Wum for the sake of this presentation. Wum was a very interesting gentleman. He had a very bubbly personality. He was very jovial. He was loud, and he was very friendly with all of the staff at the isolation center. So he presented with a 5-day history of hotness of body, joint pain, anorexia, and a 3-day history of difficulty in breathing associated with general body malaise. As per the HPI, he was last well until around 6 days prior to admission when the above symptoms began. He had visited a peripheral dispensary where he was treated for malaria, but reported no improvement. The difficulty in breathing was present throughout most of the day, associated with a mildly productive cough. As per the past medical history, this was the gentleman's index admission. He had no history of major illnesses. He had no comorbidities. As per the family and social history, Wum is a scuba diving instructor in Diani, where he lives with his wife and
Doc,
yes.
Dr. Shazim, I'm sorry to interrupt. The internet is breaking a bit. Maybe you could consider putting off your video so that we have a slightly better.
Sure.
So just go back on the slide so that we see the previous slide.
Yes. I hope it's better now.
Yes, it is. Thank you.
Okay, sure. So Wum is a scuba diving instructor from Diani, where he lives with his wife and children, who are in primary school. Wum actually denied vaccination for COVID, although he was in the age group which was eligible for vaccination, stating that he did not believe in the existence of the pandemic. Funny enough, Wum was one of our patients who remained in denial about him having COVID. Yes.
Dr. Shazim, I'm sorry again, I'm interrupting you. Consider lifting your microphone off your shirt because you're hardly able to hear so that it's clearer.
So let me try disconnecting the earphone. and use the
Okay, you can go back. Yes.
So he denied vaccination, although he fell into the eligible age group, which were being vaccinated. He had no history of smoking or alcohol use, which he persistently kept mentioning when we were admitting him and we were telling him that it looks like his lungs have quite some significant infection. He insisted that he is very active, he scuba dives, and he can hold his breath for very long. So he was really confused as to how his lungs have gotten that badly damaged. As per the inquiry of systems, there were no significant complaints noted. On examination, he was sick looking, he was in obvious respiratory distress. He had a BP of 124/72, pulse rate of 121. Respiratory rate was elevated at 32 breaths per minute, and he was having a temperature of 36.8 degrees Celsius. On admission, he had an SpO2 of 85% on room air, which improved to 91% on 15 liters per minute via a non-rebreather mask. We got some investigations done before we admitted him to the isolation unit. The CT scan showed bilateral extensive ground glass opacities to suggest an atypical pneumonia of COVID-19 with a severity score of 20 out of 25. The full hemogram showed some leukocytosis with neutrophilia and lymphopenia. His platelet count was okay at 240 and his HB was looking healthy at 16.2. His CRP was elevated at 47.45 and D dimers were also slightly elevated at 3.0. Normal range was less than 0.5. So we made an impression of COVID-19 pneumonia with the patient still under investigation and admitted him to our isolation unit, where the therapeutic plan was as follows. We got him the nasopharyngeal and oropharyngeal swab for the SARS-CoV-2 PCR the following day, which turned out to be positive. We started him on IV dexamethasone, 6 milligrams OD. We started him on a therapeutic dose of low molecular weight heparin, Clexane in this in this context is the commercial name, at 80 milligrams BD.
We've lost you for a second. Huh? Dr. Shazim, we seem to have lost you.
Okay, how about now? Can you hear me, Dr.
Now we can hear you, yes.
Okay, sorry about that. Carrying on with our therapeutic plan, we started him on dexamethasone, Clexane 80 milligrams BD as a therapeutic dose. We gave him IV paracetamol. We started him on an IV antibiotic levofloxacin, 750 milligrams once daily. We gave him nebulization with budesonide, Pulmicort commercial name in this case. We gave him an expectorant cough syrup for 3 days. Of course, we put him on vitamin C, vitamin D, and zinc, and we started him off at 15 liters per minute via an rebreather mask of oxygen. So on the first day post-admission, we were working with the diagnosis of confirmed COVID-19 pneumonia, and Wum was doing oxygen at 15 liters per minute, but he complained of having a worsening difficulty in breathing, and he was also very restless. He was still very sick looking, in respiratory distress. Oxygen now had gone down to 89% on 15 liters per minute via an rebreather mask. And on the first day post-admission, we also noted him to have elevated BPs of 150/89. So at this juncture, we increased the oxygen to 25 liters per minute via the non-rebreather mask and an additional 10 liters via nasal prongs, whereby his SpO2 went up to 92%. We got the chest physiotherapist on board, and also the psychologists to review him. And we gave him some sedation with the intramuscular haloperidol at 5 milligrams per required need. And also we decided to monitor his blood pressures, as this was the very first high BP reading we had gotten from WoM. So on the second day, we were still working with the diagnosis of COVID-19 pneumonia. At this point, WoM was on oxygen. We call it dual oxygen whenever we are giving a patient 25 liters per minute via an rebreather mask and nasal prongs. And WoM was still confused. He was still having difficulty in breathing, and he was having a lot of fatigue. Of interest here is that WoM also kept removing his non-rebreather mask every now and then, and he was confused mainly because he did not come to the fact to accept that he actually has COVID. So he was very sick looking. SpO2 now had gone down to 84% on dual oxygen at 25 liters per minute. BP was still elevated. So we got some blood panels repeated after the second day of admission. The CRP had gone up from 45 to 226. The D-dimers were also elevated. Troponins were within normal. So at this juncture, we increased the intravenous dexamethasone to 6 milligrams BD. Remember, we were giving him OD initially. And we moved him to ICU, the COVID-19 ICU, where we initiated him on non-invasive ventilation, with the vent settings having a PEEP of 8, pressure support of 10, and an FiO2 of 100, whereby his SpO2 rose up to 93%. At this juncture, we also considered talking to the relatives about getting him tocilizumab and remdesivir, while the chest physiotherapists continued with the breathing exercises, and of course the psychologists were also on board counseling him and giving him psychotherapy. So on the third day post-admission, we diagnosed WoM with the COVID-19 pneumonia, also with hypertension, as on the third day his BPs were still elevated. He was still in respiratory distress, and he kept removing his NIV mask because of confusion. At this juncture, the relatives had agreed to buy remdesivir and tocilizumab, on which we started him on. We started him on amlodipine 5 milligrams OD as well for the hypertension. And we increased the non-invasive ventilator settings from a PEEP of 8 to a PEEP of 10. We went up with the pressure support from 10 to 12, maintaining an FiO2 of 100. And we counseled him thoroughly not to remove the NIV mask. On day 4, WoM was still in mild respiratory distress. SpO2 now had started maintaining at 98% on non-invasive ventilation with a PEEP of 10, pressure support of 12, FiO2 of 100. And while feeding him, we used to remove the NIV mask, and he used to go down with the SpO2 down to 82% on room air. BP seemed to be under control at 133/73. At this point, on the fourth day of admission, we repeated the CRP, which had gone up further to 233. The procalcitonin was slightly elevated, and the full hemogram still showed us a neutrophilia and a leukocytosis. At this juncture, we considered changing the antibiotics from IV levofloxacin to IV piperacillin tazobactam, so as to cover any possible hospital-acquired pneumonia he might have picked up. On the day 5 post-admission, this was his third day on the ventilator, on non-invasive ventilation. WoM still had some difficulty in breathing. He was still sick looking, in mild distress. Although the SpO2 had started maintaining at 97% with a PEEP of 10, pressure support of 12, and an FiO2 of 100%. His respiratory rate had gone down from the low 30s to 26 breaths per minute, and he had a pulse rate of 88 beats per minute. At this juncture, we started going down with the vent settings. We reduced the FiO2 to 90, and his SpO2 maintained at 95%. So this was a good sign. And until the 6th day of post-admission and the 4th day of non-invasive ventilation is when WoM started finally showing us some signs of improvement. He himself reported a lot of improvement in the difficulty in breathing. Although he was in mild respiratory distress, the SpO2 had maintained at 99% on NIV with a setting of 10 on the PEEP, pressure support of 12, and an FiO2 of 90%. At this juncture, we decided to continue chest physiotherapy, and the plan was to still gradually wean him off the ventilator. On the 7th day post-admission, which was his 5th day on the non-invasive ventilator, Whom reported improvement further, and also in his general well-being. He was still sick looking in mild respiratory distress. His saturation was maintaining at 98% on NIV with a PEEP of 10, pressure support of 12, and an FiO2, which had been lowered to 80%. So we decided to continue the treatment as per the T-sheet. We continued with chest physiotherapy, and we continued weaning him off the ventilator and reduced the pressure settings to a PEEP of 8, pressure support of 10, and an FiO2 of 70. On day 8 post-admission, Whom further reported improvement. He was doing very well. This was his 6th day of non-invasive ventilation. SpO2 was maintaining at 99% with the NIV settings at a PEEP of 8, pressure support of 10, and an FiO2 of 70%. We further reduced the NIV settings to a PEEP of 6, pressure support of 8, and FiO2 of 60%. We continued the treatment as per the T-sheet. We also continued with physiotherapy and counseling. Now on day 9 post-admission, where he had completed 7 days, or rather it was his 7th day of non-invasive ventilation, is when we realized that we can actually wean him off the ventilator. And we tried giving him oxygen via an under-breather mask at 15 liters, whereby his SpO2 maintained at 94%. We repeated some investigations. The CRP had started going down from 230 to 180. The D-dimers had gone down, still elevated, but above the normal ranges. And the procalcitonin had also gone down. Over here, we reduced the steroid, the dexamethasone, to 6 milligrams OD from BD. We weaned him off the vent. He saturated well on 15 liters per minute and continued giving him physiotherapy and finished the antibiotics as per the T-sheet. So on the 10th day post-admission up to the 12th day post-admission, we gradually weaned Whom off the oxygen. He completed his IV antibiotics. And on the 12th day post-admission, which was on the 24th of June, we discharged Whom home for home-based care and isolation via our public health department, which followed him up after 2 weeks, where we did a PCR test on him. It was negative. We also tested his family. They were all negative. And we called it a job well done. Yes, these were some of our key observations as far as the case of Whom is concerned.
Many thanks, Dr. Shazim, for that presentation. We're glad this patient did well, and we just want to review the case and point out some of the issues that we should all be watching out for, both in the medical management as well as in offering oxygen and respiratory support. So I'll just make a few observations in the medical management, then I'll also ask Dr. Okioma. I don't know if Dr. Mugera has joined us as well. I'll ask Dr. Okioma to make some comments as well. So maybe let's go to the beginning of Whom's presentation and the initial workup of this patient. So I know part of the key observations was having regular monitoring of some of the inflammatory markers. So I guess one of the questions you always ask yourself is, why am I doing a test? How will this test help me in the management of the patient? So for a patient who's just come in with COVID pneumonia, there are certain tests like a CRP is going to be high. It is going to be high because the patient has a lot of inflammation in the lung. Does it actually change what you do at the outset? No, it doesn't. So for those who do not have capacity to do CRP, don't feel that you're doing the wrong thing. When we know that the CRP is high, it's often an indicator of more severe disease or of disease progression. So it could be a prognostic indicator. The other question was about D-dimer, and we've talked about this several in the previous webinars. So again, in the beginning, people thought, if you have a high D-dimer, maybe you need to give a higher dose of Clexane. But the truth is, all the studies looking at whether D-dimer predicted need for prophylaxis or for therapeutic doses have been negative studies. So there have been also a lot of studies looking at whether to give a patient therapeutic versus prophylactic doses. And I think overall we agree that we should give patients prophylactic rather than therapeutic doses. And if you strongly suspect a PE, then go ahead and do a CTPA. If there's a PE, then you'd move on to therapeutic doses. The few other tests like the white cell count is good. A lymphopenia often again predicts severe disease. Okay. When we go to the initial therapy, I've commented about the Clexane. Again, let us stick to giving our patients prophylactic Clexane unless we have identified a clot. Okay. Again, for the levofloxacin, remember this patient, this time the patient had a low procalcitonin. We knew the patient had pneumonia, so let us practice more antimicrobial stewardship so that we do not use broad spectrum antibiotics for patients with COVID. We've variously commented on the issues of vitamin C, D, and zinc, and we know from all the data that has been submitted so far, these are not necessary for management of COVID. Going on, there's a lot of controversy around the issue of higher dose dexamethasone. Remember, higher doses of steroids often put these patients at increased risk for infections in the ICU. So avoid the higher doses of steroids. Some pulmonologists talk about the concept of organizing pneumonia, but still looking at the data around higher doses steroids, more recently, there's been some data emerging, but it's still very preliminary. The patient got tocilizumab, and rightly so. At that point, you identify that the patient was rapidly deteriorating and had a high CRP. As we mentioned previously, if the CRP is above 75 in a patient who's rapidly deteriorating, you want to give tocilizumab. I'm not sure what the patient's weight was because you want to give a dose of about 8 milligrams per kilo. So you want to dose it appropriately. The remdesivir was also given. We commented about the issues of remdesivir in critical care. In patients who are in critical care or severely ill, it's not very clear that remdesivir has a role. Remember, it generally does not have mortality benefit. So that needs to be clear to the relatives because sometimes relatives are really pushing that you give them this. So it's good to know the data around it. I'd commented about the issues of antibiotics. At the time of switch to piperacillin, tazobactam, this patient still had a low procalcitonin, and it's likely that the issues that we're dealing with were more of the COVID-related pneumonia rather than a bacterial pneumonia. So again, just especially in ICUs, antibiotic stewardship is critical because otherwise you end up with an ICU where you have a lot of drug-resistant bugs. Dr. Okioma, if you can hear me, I'd just like you to comment on some of the issues around. I mentioned some of the issues around oxygenation. We noticed that in the beginning, the patient was on NRM, then went up to 25 liters per minute, NRM and nasal prongs. So maybe just a quick recap on how we should think about oxygenation.
Thank you. Thank you. Allow me to go back a little. First, congratulations to Dr. Baga and team. I think they did very well with this patient. Just a few things I also noted, at the initiation of treatment and at the beginning of, handling this patient, there are a few key issues that are important and that may help you predict the cause of the disease for some of these patients. One, you had a HRCT that had a 20 out of 25 severity score. So that tells you that this patient is quite critically ill. Lung involvement of 20 out of 25 is quite severe. The second is the SpO2s on admission and the fact that he quickly required to be escalated from minimal oxygen to a non-rebreather and eventually to NIV. You've mentioned the issue of antibiotics, but let me also mention that we at times receive patients who have already been pre-medicated or self-medicated themselves with lots of antibiotics, and it becomes difficult to choose which antibiotics to start them on. There was a cough syrup added there And we have to be careful with some of the cough syrups that we put patients on. Some of them, especially the expectorant ones, they tend to cause lots and lots of coughing, and that is not going to be good, especially if you're going to put your patient again on a non-rebreather mask or NIV. About Crexane, I agree with you in terms of being careful on the doses that you start. I should, however, mention that we have seen lots and lots of DVT and pulmonary thromboembolism with the current wave than any of the last 3 waves. We have had about 6 cases of DVT related to invasives within the last 2-3 weeks. And we have made it a policy to use 40 milligrams BD for patients who are in ICU and have invasives, just to reduce the risk of getting PE. We are able to do D-dimers quite often, and they are quite elevated, as you say initially, because of the disease per se. But if you have a very rapid increase in D-dimers, I think this patient had that from 3.0 to 17.6. That's such a significant change that would have warranted a consideration of PE. Remember, you can have PE without DVT in these patients. Now, coming to the oxygen, which is also a very, very important point. You began with NRM and then you added nasoprons to get to 25 liters. Our policy is once a patient gets or requires more than 15 liters, then the next thing is really to consider a more definitive way of delivering oxygen, of supporting oxygen. You need something that generates pressure, not flow, and that's where now NIV becomes important. In my view, any patient who requires more than 15 liters should be escalated to NIV, or at least a high flow nasal cannula, which can generate lower levels of PIP. Allow me to also mention a few other things. One, there was a lot of confusion with this patient, and it may not just be the denial that he is COVID positive. Yes, that could be, but also don't forget about delirium that is related to critical illness. And having a psychologist or even a psychiatrist give you input for this patient would be very important. You mentioned the issue of dexamethasone. I think the recovery study did show that only 6 milligrams OD showed benefit vis-a-vis higher doses. And I think there are a number of studies that have tried to compare 6 milligrams to 12 milligrams a day. And there was no added benefit in using the higher doses. What you actually get is lots of challenges with blood sugars and of course some immunosuppressive effect. The use of tocilizumab with remdesivir is still a point of controversy. In my view, patients who are early in the course of their disease, at least 10 days from onset of symptoms, tend to do very well with remdesivir and baricitinib as a combined treatment vis-a-vis using tocilizumab early in the disease. Later in the disease, especially with the cytokine storms, then tocilizumab becomes important. The question, of course, is what is the weight of the patient? Do you want to give a start dose? Do you want to give 2 or 3 doses? Those, I think, can be discussed with the specialist. Although in my view, rarely do you require more than a single dose. And it is very difficult also to determine which patient will benefit from tocilizumab because we are not able to measure, for example, interleukin-6 levels to determine that a patient is actually in a cytokine storm. But there are lots of suggested criteria for determining the use of tocilizumab and specifically, confirming that a patient has a cytokine storm. You were able to wean this patient off the NIV gradually in a very good way, and coming down on the PIP, and the pressure support is a good indication that your patient is going to tolerate being off the ventilator. However, an FiO2 of 60 may be on the higher side to get off the NIV. We tend to succeed more when we have reached FiO2s of between 35 and 45 in our unit. But I do know at times you also have the pressure of wanting to have to get another patient on the ventilator. Lastly, compliance with the NIV requires a lot. We did talk about this last week. Making sure that your patient is comfortable on NIV is likely to give you better results. One of the things we have noticed that improves outcomes is humidification. You need to ensure your circuits are humidified, and this is because the patient's mouth and nose do not become very dry, and that is the commonest cause of agitation and non-compliance with the NIV. The other thing is, of course, having a light-sized mask and something that protects the nasal ridge or bridge from pressure. And then the last thing is, what is the expected cause of such a patient? You know, patient who requires NIV. Majority tend to follow the pattern that you have described, such that by day 7, day 8, probably up to day 10 of NIV, you are able to win them off, and they are able to go on and do quite well. That's all from me, Royce.
Thank you so much, Dr. Kioma. I think you really handled the issues well. Maybe just an additional comment, because you talked about this, the issue of remdesivir plus baricitinib. And maybe just comment that this should ideally only be used in patients who are unable to use steroids, and mainly because a lot of the data that we have on remdesivir and baricitinib was in studies carried out before dexamethasone. And some of the data we have from dexamethasone shows even better outcomes than what was gotten with remdesivir and baricitinib. So it really should be left for patients who are unable to use dexamethasone. I guess for everyone else, they've commented about the severity, 20/25. That basically means that about 80% of the lung is involved. That when you look at the CT scan, about 80% of the lung. So that's why you're saying that's very severe disease. Dr. Mugera, you've joined us. I just wanted you to comment on two things. So one, there's a question, people are struggling with feeding of patients who are on NIV. I don't know how you'd advise them to go about this, especially where a patient desaturates significantly when they remove the mask. Dr. Mugera, I don't know if you're able to hear me. Had you promoted her?
Yes, I have.
Okay, so we can't hear Dr. Mugera, but maybe Dr. Kioma can come back to you again. How, in your experience with all the ICU patients, what's the best way to take care of their nutrition?
Thank you very much. We have what I would call a blended way of dealing with that, and it depends on exactly what mode of oxygen delivery are you using, or which device are you using. If a patient is on nasal probes, that's easy, or is on a high flow nasal cannula, then they are able to take orally, and majority are able to really achieve their nutritional, daily nutritional requirements with that. The challenge now comes with the face mask, a non-rebreather mask, or NIV, especially in situations where patients are not able to tolerate brief periods off the mask, whether it is really to chew or just to put the food in their mouth. So for the helmet NIV ventilation, we have found ways of giving branded food, puree food, through an NG tube, and that has been effective. Although in a number of situations, we have required to supplement what we call supplemental parenteral nutrition. There is a risk, of course, when you put a CVC on a critically ill patient, there's a high risk of getting nosocomial infections, bloodstream nosocomial infections. So what we have done is not to use central venous catheters, but use peripherally inserted central venous catheters more. they have a lower risk of getting UoN infection and also a lower risk of getting DVT. For those patients who are on mechanical ventilation, then there are two considerations. One, you start the first 24 hours on TPN if possible, or just IV fluids, and then transition as soon as you can to enteral feeding through NG tubes. That is the preferred mode. And remember, you can even use kitchen feed so long as they are well blended. And to improve absorption, we tend to give laxatives and prokinetics such as Placil or erythromycin from the beginning. You do not wait for them to get constipated. And then, of course, avoiding other drugs that may cause constipation. And morphine is one of them, and tramol that you have to always look out for. So you go for enteral feeding as your first line, and until you are not able to give food enterally, then you do either supplemental or total parenteral nutrition.
Thank you very much, Dr. Okioma. And maybe Dr. Mugera, I hope you're able to hear me now, just to bring you in and make a comment on monitoring of the patient who you're giving non-invasive ventilation. At what point should we do a blood gas analysis? How can we monitor this patient? For example, about this patient, how is there anything they would have done better in terms of monitoring? How frequently, and how do you respond to that as well?
Right. Thank you. And so, unfortunately, I came in late, so I might not be able to comment on the specific patient. However, monitoring of your patient, every time you make a change on your ventilator or your NRM, when you move from nasal cannula to NRM, you give at least 30 minutes to an hour to repeat a blood gas. Every time you do an intervention on your patient, you take about 30 minutes to 1 hour to do the assessment, the reassessment. Ideally, you should do your reassessment of your blood pressure at least every 3 to 15 minutes. Reassessment of your intervention for your oxygenation should be at least every 30 minutes to 1 hour. So I didn't see the whole case, so I can't specifically give you details for this case. Just to add on to what Dr. Okioma said, indeed, always is the blended. We always want to keep the gut flora alive. So as much as possible, even if you're giving a few sips of yogurt or mala anytime during the day, it's a good idea to always try enteral feeds. But yes, parenteral nutrition, either peripherally or in a central line, is a good idea for patients on NIV and even helmet. Thank you.
Thank you very much, Dr. Mugera. I know we also have Dr. Wanjiru, who's the physician in CGHRH. I don't know if you want to make just a 1 minute comment before we go on.
Good morning, Dr. Lois. I'm not a physician, I'm a clinical pharmacist.
Okay.
My interest mainly in this case would be the operations. I'm the chair for the advisory committee for COVID response at the hospital. Thank you so much for giving us this opportunity. And thank you, Dr. Shazim. It was a wonderful patient. They have covered everything. And I think we're going to have a very lively discussion back at the unit as soon as we get this recording. Thank you to the whole team for giving us the opportunity, and two, the feedback. Asanteni.
Thank you so much, Dr. Shazem. You've helped us to learn a lot of things. We are really grateful, and we really salute you and the team for the excellent work that you're doing with the patients. So you can take down your presentation. So there's always this question that we've had. Sometimes you have a patient who comes in and they've been on oxygen 10 days. You've managed to wean them off ventilator, but they're just hanging in on oxygen. You can't get off the oxygen. So at what point is it safe to send a patient home on oxygen? How can they safely deliver oxygen at home? How do we monitor patients who are on home oxygen? So those are some of the questions that Dr. Waweru will help us answer next. So Dr. Waweru, karibu.
Thank you very much, Dr. Lois. You know, I'm a pulmonologist, so I would like to comment also. You can hear me, Lois?
Yes, we can hear you.
Okay, I would like to comment about the case we've just discussed and the role of budesonide in such patients. I noted that the patient was nebulized with budesonide. The evidence that we have so far shows that there is no benefit of nebulizing these patients in hospital with budesonide or indeed any other nebulized steroid. The only patients who appear to benefit are those patients who are at high risk of progression and are still at home. With those ones, you can give them budesonide inhaler therapy and see how it does. Although even there, the evidence is not so robust, people are still working on it, but we have a few positive studies which have shown some benefit. Thank you. So now switching on to my presentation, I would like us to look at how we can do a home oxygen therapy effectively and a few good things about home oxygen therapy, as well as how to look out for problems when we are doing these kind of things. And as a way of introduction, we do know that currently there's a lot of shortage of beds in hospitals. Patients are lingering on in hospital for a long time, just requiring 2 to 3 liters, 1 to 2 liters of oxygen per minute through prongs. And therefore, we have to think of ways in which those patients who are stable can be allowed to go home so that we open up the beds for those patients who are acutely ill and need to be stabilized. Now, we also do know that we are having very high volumes, and these volumes keep fluctuating. Sometimes you'll have few patients, other times you have very many patients, and therefore we need to be in such a situation that we can scale up our patient care as and when this demand becomes necessary. One thing we know in patients who have got COVID is that the key problem they will have is low oxygen saturations. And so by using home-based oxygen delivery systems, we can help these patients go home better. We have discussed this previously, and we do know that many patients, you only require low oxygen flow, where we give them oxygen via nasal prongs. We give 1 to 4 liters. If you notice on this chart, we are talking about 1 to 6, but it actually should be about 1 to 4 liters, because beyond that, we want to go to the face mask, which can also be used for up to 10 liters per minute. If that is not achieving our goals, then we go to the non-rebreather or high oxygen flow mask, which we can give up to 15 liters. Dr. Okioma has made a point that if you find your patient requires more than 15 liters via non-rebreather mask, please consider that patient for some non-invasive method of ventilation, either using high flow nasal cannulae, or you use a non-invasive method such as the face mask or the helmet. And then when we use high flow nasal cannulas, we've agreed that we only give up to 60 liters per minute. If you find your patient is requiring that, then you need positive airway pressure. You give either, for most patients, CPAP will be the preferred mode, but eventually, of course, we do know some patients who are very, very sick or may not be able to tolerate the CPAP for one reason or another. In those patients, we may give them ventilator therapy. When this COVID pandemic started, we know that some people even bought ventilators for home use, and I think they still have these ventilators. So is it every patient who has COVID and requires oxygen that can be managed at home? As we discuss this question, we need to know that patients are very afraid. Many patients are afraid of coming to hospitals. And so a lot of education needs to go in to help patients determine when is it risky for me to continue staying at home. Secondly, we do know that some people would even like to be ventilated in their houses. Or, you know, people are different. They would rather not come to hospitals. So are those, if a patient requires ventilation, is it safe to do it at home? Well, that's out for discussion. So the advantages of domiciliary oxygen therapy or short-term oxygen therapy is that it is less expensive than staying in hospital. And this cost is not just in the sense of money. Money is, of course, very, very important, but also for the healthcare system, it is better to get this patient home sooner, because we also have to think about complications such as healthcare associated infections, their emotional costs with the families always have and not knowing what is going on with their patients. So as much as we can, let us get these patients home so long as it is safe. Then patients generally would like to be at home because it is warmer in the home. People can come and see them, even if it is through a window or something like that. If they want a particular type of food, they'll get it prepared the way they want at home. So really, most patients would prefer to be at home. Remember also that some patients get extremely bored staying in the hospital. And you may find that a patient has required 2 liters of oxygen for about 2 to 3 weeks. Well, that's a patient whom we should consider sending home. And then we've already talked about this, the amount of pressure that hospitals are under to get the really sick patients in. And yet you have several patients who will still not be able to go home unless they have an oxygen system at home. So which patients must we keep in hospital? Because not everyone qualifies. Of course, any patient who is very, very unstable, patients who are in HD ICU, of course, that goes without saying. But for those patients who are in the ward, for example, you find a patient is on only 2 liters, and with that, they are doing 90–91%. But the moment they move in the bed, their saturations drop drastically. That is a patient you want to take your time until they are able at least to walk a bit in the ward before you send them home. Remember, when this patient goes home, they may want to go and sit in the sun, they may want to go and take a shower. And unfortunately, these are times when, if they are active, their oxygen demand is higher, and many people don't recognize this. You may find a patient when they're walking outside or they're exercising, they disconnect the oxygen, which is actually a risk to them because they may get profoundly hypoxemic, and many patients have collapsed in their houses because of this hypoxemia. So if your patient is having low saturations within the ward, please consider keeping this patient until their saturations are better. For patients who are unable to cooperate, the case we have listened to before, this patient at some point was quite confused. And therefore, sending such a patient at home who is already removing a mask from their face, you wonder how the family will be able to, number one, keep the mask on the face, because the patient can bulldoze and say, I don't want it. Number two, even if you had a nurse with them, they may not be able to do or to keep an eye on this patient 24/7, as can happen in the ward. The other thing that may happen is that these patients may not follow instructions well enough. So if a patient is unable to cooperate for whatever reason, this is a patient you want to consider to stay in. Number three, if your patient has shown clinical deterioration. For instance, we have many patients in whom we plan to send home the following day. And then you come in the morning and you find, oh, this patient yesterday was on 1 liter, but now is on 5 liters and the saturations are only 89. That one you need to keep an eye, diagnose the problem that has caused them to require more oxygen, sort it out before you send them home. There are also CNS complications. Some patients start getting confused, excessively dizzy. That's a patient you want to keep in the hospital. Or if they have gastrointestinal system problems, they are not drinking enough, they're having diarrhea, they have all these things, you make it more difficult to manage this patient at home. Comorbidities, very, very important. We do know many comorbidities, and I will highlight a few of them as we go along. If your patient is having very fluctuant sugars, for example, the family is unlikely to be able to manage that patient at home. Or if they are undergoing renal dialysis and they are still having low saturations, you want maybe to watch that patient a day or two more, make sure they are completely stabilized before you send them home. There are people who are living alone or do not have an adequate social support system. And therefore, this is a patient who is likely to sleep the cannula slip off and nobody will notice until the following morning, and they may get excessively low oxygen saturations. So let us evaluate how is the home environment for this patient. Are they likely to get adequate supervision? Is there someone who is going to keep monitoring them, monitoring their oxygen? If they need sugar monitoring, that also is being monitored. So a responsible caregiver needs to be available to watch this patient throughout, so that we are sure they will get a good outcome. And then we need to make sure that these patients have a reliable oxygen source. And what we usually advise our patients to do is get an oxygen concentrator, but also have a cylinder on standby. We do know that in this town, it's very, very common to have power blackouts. So if you get a power blackout, even if you have the best concentrator, it is basically useless. So you need to plan for a backup, either backup power or a backup oxygen source, so that your patient is able to get continuous oxygen therapy. And this also emphasizes the need to have a patient who is not desaturating excessively, because sometimes it takes time between the time the patient's oxygen source runs out and the time they get an accessory source. So all these things must be educated to the patient, and we must, as far as is possible, assure that these things are available before we allow our patients to go home. So what are the challenges we have in deciding about domiciliary oxygen therapy? Number one, proper patient triage. This one will help us decide this patient is likely to do well and this one is unlikely to do well. Number two, patient monitoring when they go home. We also have misconceptions about this oxygen therapy. We've already discussed about those patients who are not fit enough to go home. But we also do have families who, for different reasons, maybe financial, or they don't want to stay away from their patient. All these things can come in and be important decisions or discussions with families and patients before we send them home. And whatever misconceptions the family or the patient may have about home oxygen, we need to allay their fears or educate them in how to overcome those problems. Another problem we get when patients go home and they are using oxygen at home, or a patient was seen in A&E, a decision was made for them to go home. They notice that they are desaturating. A neighbor of theirs had COVID and has an oxygen concentrator, and they give him this concentrator and he's staying at home. One problem that occurs with that, especially if the family is not well educated in these matters, is that they may stay home too long. And by the time they are coming to hospital, you may find that your patient is irredeemable. So education must go in, even when you are giving these patients, we must give specific trigger points where if they reach that, for example, you may tell them, if you find your saturations are below 88%, and it's not coming up despite escalating the oxygen therapy, that patient should not stay at home, should come to hospital for evaluation and proper management. Then we've already discussed about interruptions in oxygen supply. This may be a problem with the concentrator itself, power source, cylinder exchanges, because you remember there's a lot of logistics that goes on into having cylinders. And what I have found works is that if my patient chooses to use cylinders rather than to get a concentrator, I usually will ask them to get the large cylinders and to get 3 of them. One is to be used by the patient, one is on standby, and the third one has gone back to be filled, so that at no time is the patient having only one cylinder. Because unfortunately, most of the systems we have here are not able to tell you accurately when the oxygen is about to run out. And we have had situations where patients' oxygen runs out, and now they are caught. They have 2 empty cylinders because it is Sunday and the place where they fill their oxygen is closed. That becomes a problem. Number 4 is that there may be spread of infections, especially if patients share these machines. And we must also remember that all these things, the cylinders, the concentrators are not cheap. For instance, currently in the market, most affordable new concentrators will cost anything from about 70, 90,000, and there are some which will cost up to 150,000. So for many families, this may be very, very high. But what COVID pandemic has done, is that it has made people become innovative. And now we do have companies who are able to lease out these machines. For instance, if you find your patient requires oxygen, maybe for a week or 2 weeks, it may not make much sense for them to buy a machine. It may be better they just lease a machine for 2-3 weeks and then give it back when the patient no longer needs it. We must also remember the logistics. If a patient, for example, is using cylinders, how will these cylinders be refilled? And that has to be really considered, especially in the rural areas where the oxygen vending companies may not have branches. So it becomes an important thing. You may even have to ask patients, and we have asked some, please don't go back home, get a B&B here in town, stay for a month, get off your oxygen, and then you can go back home. That is in those cases where patients are unlikely to get good replenishment of their oxygen. We talked about triaging patients who are fit to go home. And we have this diagram which starts at assessing the patient and seeing what saturations they have. If a patient's saturation is less than 19, either at rest or not, we check whether that is stable. Because if a patient is just turning in bed and the saturations are dropping to the 70s, then you know that that patient is not fit to go home yet. And therefore, that patient may not be eligible for home oxygen therapy. However, for those patients who are having good saturations, maybe they use 2-3 liters of oxygen now, and they are fit, even when they walk around the bed, the saturations are not dropping, especially when they are on the low flow nasal cannulae. Those are patients who are eligible for the short-term home oxygen therapy. And therefore, you can advise those ones now to start planning for home oxygen therapy. For those who are unstable, let's look for the reason why they are unstable and sort out that problem. Gradually reduce our oxygen supply. If we are using 5 liters, we come to 4, come to 3, and so on. And then we need to regularly monitor the oxygen saturation by using the pulse oximeters in most cases. You may also use blood gases if indicated. And then you gradually wean them off until they are reaching a range of maybe 3 to 4. Most of the concentrators you have in the market are able to give between 5 and 10 liters of oxygen per minute. And so you have to appropriately advise your patient. If they are using, like, let's say 4 liters, you would like to have a redundancy of a few liters. So you may tell that particular patient, instead of getting a concentrator giving 5 liters max, get a concentrator giving 10 liters, so that even if they go home and their requirements go up slightly, they are still able to match their requirements. And then if your patient is at any point not coping well, even when they are on those the liters, like 4-5 liters like that, you may want to optimize them first before you send them home. As we assess these patients, we need to find out whether they have high-risk comorbidities, because some of these high-risk comorbidities may make it more difficult for the patients to manage at home. If they have active kidney disease, for example, you may want to stabilize that. If they have HIV, which is not well controlled, people who are smoking, pregnant women, and it appears that this wave has particularly affected pregnant women. In all the hospitals where I work, I have at least one patient who is pregnant. So these are high-risk patients. And when you are making a decision to send them home, we really must take care that they have the right support, they have the right equipment to take care of themselves at home and to monitor themselves at home before we allow them to go home. Other patients who are high risk are, for instance, patients who have substance use disorders, people who are taking too much alcohol, smoking different things, because these patients may not be able to properly follow instructions. Patients with conditions like heart failure, coronary artery disease, especially if active, you do not want to send such a patient home. Diabetes, very, very common, triggered by COVID itself, triggered by the medications we are giving. Patients who have had diabetes before are also going out of control. Let's make sure the patient has been properly controlled, the sugar levels are okay, and then they have someone who can monitor them at home. Because remember, if they are going home and they are using steroids, after some time they'll stop using the steroids. And at that time, if they are on hypoglycemic drugs, either insulin or others, they may go into hypos. So even as we see that their oxygen requirements are low and they can go home, let us not forget all these other high-risk comorbidities and manage them appropriately. Now, when we educate the patient, we must also educate the family. And one thing which I have found important is we must emphasize that patients require more oxygen when they are active than when they are at rest. Many families test their relatives only when they are resting. But when they walk around in the compound or doing a bit of exercise, nobody remembers to check them. But if you check these patients when they're in the ward, you may find that they are quite comfortable. 2 liters is giving them 98%. The moment you tell them to do a little exercise, you find that the oxygen saturations plummet, sometimes even to the 70s. So it is important to educate the family that when your patient is exercising, let them exercise while still on oxygen, monitor, because many times you'll find that you need also to adjust the oxygen delivery higher. So if a patient was on 3 liters, you may need to go up to 4 liters to make sure that these oxygen saturations are staying within acceptable range. Another thing is that we do know that when patients are asleep, or even anybody, many people actually desaturate at night because they are breathing less deeply. So it is important when these patients go, let them have someone to check their oxygen saturation at some point in the night, because many times you may find that their oxygen levels have gone too low and they may need to have it increased for better oxygenation. Please ask the person selling the machine to the patient to educate the family about how to take care of the machine, how to add water, for example, for humidification, and also how to troubleshoot. Some alarm may go off and maybe it's a very minor thing, maybe an electrical fluctuation, and patients will start panicking. So it is important that they are trained how to use the concentrator properly or even the cylinder, and then also to do simple troubleshooting. They also should know when the machine is not delivering so that they can shift the patient to the backup system. And then patient monitoring is also very, very important, especially recognizing that patient has deteriorated and therefore the system is not achieving the desired goal of maintaining a good oxygen saturation. Because in that case, that patient needs to go back to hospital for a reassessment and as well as get the oxygen until their requirements drop. There must also be clear instructions to the family and to the patient what to do if the patient is not doing well. They need to have a good number, a phone number, which is monitored, because sometimes they may have an acute problem and they call the hospital number and it goes unanswered. Maybe it's a clinic number, it goes unanswered. So there has to be a way in which the patient's concerns or patient's problems are easily sorted out. Something which has come up also is this thing of telemonitoring. This is where there are some gadgets in the market. For example, a patient may have a pulse oximeter at home, and that pulse oximeter can be accessed by the physician. But a simpler thing is, as the family, please do your saturation morning, lunch, and evening. Take a picture, send to me on WhatsApp, so that you see, has this patient's levels been okay during the day? And this will make it much easier for the clinician to give advice to the family if things are going wrong. There's a tool which we call the breathlessness screening tool. This is a tool which has been tried and it has been found to correlate with the saturations, and it is easy. You just ask a patient to take a deep breath in and they start counting up to 30. They count in the language they understand best. And then if a patient is able to count up to 30, for example, then that patient is unlikely to be hypoxemic. But if they're only able to count less than 7, then you know that patient is likely having significant difficulty in breathing. And therefore, you can advise them, no, I think your difficulty in breathing requires you to come to the outpatient or to the casualty for assessment. This test is important when patients call and they tell you, Daktari, I was diagnosed with COVID on Saturday and I'm coughing so much. I've done my saturation and I'm getting saturations of 90. For you to be able to say, is this a patient who is fit to come, or is this patient we can watch at home? You can administer this and see whether the patient's breathlessness is so high. So we have discussed this before. And I just want to reiterate that when we are prescribing cylinders or concentrators, each of them has advantages versus the other. And the capital cost for concentrators is generally higher than the cylinders, especially if one is purchasing them. But if you're hiring, maybe the cost is close, because, for example, a certain company I work with, they lease concentrators at, I think, 30,000 per month. While if you are getting cylinders, they will charge you almost the same per month. But if you are buying, the concentrators tend to be a bit more expensive. Running costs are high for cylinders because you have to have a logistics of getting these cylinders exchanged, especially if the patient's requirements are high. Maybe they are using a mask at home. That patient is likely to incur higher costs than a patient who is using a concentrator. The cylinders are also easy to use because you just connect the tap and that is it. Reliability, we find that concentrators, especially the good quality ones, are quite good. And the good thing is that once you fit it, you do not need to worry about when is the truck coming to bring the cylinders. The cylinders need, as well as concentrators, need some maintenance. So please, when you advise your patient to buy a cylinder, ask them to buy a cylinder or a concentrator from a reputable company who will be able to give after-sales service. Many patients get disappointed because they buy a concentrator, for example, on eBay. They are cheap. Then when they need maintenance, they find that they can't get a simple thing like a filter. So it becomes a very useless gadget, maybe after a few weeks. So the issue of electricity we have already talked about. Portability is difficult for the large cylinders, but there are some small cylinders people can lug around. Then concentrators are of different sizes. The bigger ones can weigh up to 20 kilos. The small ones can weigh maybe 3 to 5 kilos, but those tend to be more expensive. About concentrators, for those patients who travel a lot, there are concentrators which can be connected to the car charger system. So if your patient is traveling like now from Nairobi to Kisumu, you can ask the family to buy one which they can plug into the car as they travel home. Similarly, you may sometimes have to evacuate patients out of the country if they are, let's say they are from India and they got sick here and you want to transfer them back to India. When you advise these families, please ask them to buy a concentrator which is approved by the Federal Aviation Authority. Otherwise, they'll get to the plane and they'll be told your concentrator is not approved. And unfortunately, many Chinese brands are not approved. So when you're advising them, advise them to get an FAA approved cylinder. So delivery systems you've discussed about before, and for most cases, patients who go home on oxygen, they'll go home either on prongs or masks. But as we know, there are some people who have bought the high flow nasal cannula systems, or some even buy CPAP machines, especially those patients who have advanced fibrosis. Their patient requires to be on this support. So some of them can be transitioned from hospital to home for long-term care. And in that case, you may need to involve some critical care nurses to help with the transition. Eventually, most families know what is going on, but they will still need a critical care nurse to take care of them at home. Then we have to talk about patient monitoring, especially the family, and the basic equipment that they'll need is a pulse oximeter, a thermometer, and other machines based on the comorbidities. For example, if a patient has diabetes, they'll need a glucometer. If they have hypertension, they'll need a BP machine. Then telemonitoring is two-way. What I mean by this is that the family should be able to talk to the clinician, and the clinician also should be able to talk to the family if there are any interventions that were ordered, to find out, did those interventions achieve the goal that was required. And telemonitoring also, there must be 24-hour cover, so that if a problem occurs at 3 a.m., that family should get the help they need. Then we also must decide if the patient needs escalation of care, what do we do? So we must have a method of either picking the patient by ambulance or another way where they can be assisted. Maybe there's a nearby hospital they can go to and they get the initial treatment as they plan to transfer to come and see you, for instance. Now, this is basically to summarize what we have discussed. Number one, we may have to do teletriage. That is, this patient who has had a test and they feel they are deteriorating. You may have to do a teletriage. They are calling from Makindu. They want to know, should I come to hospital? I already have a cylinder in the house. What do I do? So you must ask about the breathlessness, about the symptoms they have, whether they have a pulse oximeter, and also you may sometimes do a video assessment to see, are they actually using the concentrator or the cylinder the way it should be used. And some places they have already developed mobile apps which are useful in this kind of triaging. And this triage should be done on a daily basis so that you can know, is this a patient who needs to have a reduction in the amount of oxygen or down titration of oxygen? And when we are down titrating, we come down maybe by 1 liter until we are able to liberate our patients from oxygen. If you find that your patient's condition today is similar to how it was yesterday, don't panic. That is very, very common in COVID. Just continue pushing on. Please reassure your patient, and then you reassess maybe the day after. If they are improving, then you start down titrating. But there are those patients whose requirements will increase, and if they do, we need to assess them. Is it that the disease process has worsened? Is it that they have complications like pulmonary embolism? So for those people who have significantly deteriorated, we need to ask them to come to hospital for an in-hospital review and assessment. Thank you very much.
Thank you, Dr. Owero. I think you've answered very many questions around issues of home care. And someone is asking the question, one, if you discharge a patient home who was doing well and they begin to desaturate at home. So once you discharge a patient from the hospital, what should they monitor when they go home? So let's say it's a patient who's done well, you've gotten them off oxygen. How soon after getting a patient off oxygen should you allow them home? What should they monitor at home? And if the oxygen, say, was 90% and it goes to 89, should they come back, or at what point should they come back?
Thank you, Lois. So I'll start from behind. If your patient went home on an oxygen level of 90, the key thing is to find out, is the deterioration persistent? For instance, if they measure an oxygen and find it's 89, and then in the evening it's back to 90, maybe you don't need to panic. But if you find a patient has measured an oxygen is 89, then later in the day it's going to 84, then later in that case, you need to ask a patient, please come back for evaluation. It is more not a single reading, but the trend within a few hours that will help you. But also, it's not just the oxygen saturation that is important. What is the patient's other systems doing? For instance, they may find a saturation of 89, but this patient has had severe headache. Maybe you need to see that patient sooner rather than later. Number two, the things that they need as baseline for monitoring is a pulse oximeter, a thermometer, and disease-specific tools to assess. For example, if it is diabetes, a glucometer. If it is blood pressure, BP. And then they need clear guidelines. If you find your BP is this reading to this reading, get in touch. If you find your sugar is above this reading, get in touch, or below this reading, get in touch, so that you can then do your tele-triage and find out, is this a patient who is safe to stay at home, or do I want to see them immediately?
Thank you very much, Dr. Oweru. I think that's one of the areas where many facilities need to improve on. Often when a patient is discharged, it's you're well, go. But how well they're able to monitor and what they should do is then something that we, all of us then need to routinely talk to our patients about. Sorry, just one more question. I'm trying to find another question. Or someone has asked this question, and maybe you can clarify. It's not related to home oxygen therapy, but it's one of the questions on the platform about the issue of pulsing patients with high dose steroids. I know both Dr. Okioma and I had commented on the issue of high dose steroids and really the lack of evidence to support that. So what would be your take on the issue of pulsing patients?
Yeah, we do know that so far, most studies have not shown much benefit in terms of high doses of steroids. And indeed, many have shown that there is a risk in terms of infections and other complications like diabetes, GI bleeding. Patients are developing confusion or delirium due to steroids. A few days down the line, you find your patient can't get out of bed because of all the myopathy. All these things are related to high steroid doses. However, anecdotally, we have seen that some patients who have deteriorated when they are on the standard doses of dexamethasone do well, not with those very high doses of 500 milligrams of methylprednisolone, but giving them between 125 and 250 milligrams. For some of them, for a short period of time, you turn the tide. You find that the CRPs are coming down and the patient's breathlessness and saturations improve. But this has to be carefully selected. Only patients who are deteriorating, you've demonstrated that the CT scan you did came in at 18%, and now we are at 72%, despite 6 days of dexamethasone. In that case, you may consider giving some steroids. And there are a few studies which have shown that there may be benefit. Not very robust, but there are a few.
Thank you very much. Thank you very much. I don't know if there are other questions related to home care. Maybe one of the questions is, we've seen a sort of proliferation of these home care providers. And I remember, I think a week or two ago, seeing a comment from the Mombasa County government saying that they'd outlawed home care. So for home care providers out there, what's the best that they can offer, and when should they definitely consider telling a patient not to do home care?
Thank you. This is a very political question, and the reason being, hospitals are overwhelmed. And I would rather have a doctor go and see this patient once a day in the house, rather than that patient being left by themselves. I would rather this patient is taken care of by a nurse at home, rather than say, oh, there's no bed, stay at home. So that's why I say it's a dicey question. What I think there should be is regulation of these home-based companies, so that they have certain standards they aspire to, so that patients are not taken a write-off, and they are also protected in terms of what parameters can be taken care of at home, what must come to hospital. But we do recognize that there are patients who need ICU beds and they cannot get ICU beds in this town. So what we need, from my view, is that what we need to do is regulate that industry, because there is a real need, and set guidelines. You can treat this one at home, this one must come to hospital. Then client education is important, so that the patient and the families can recognize it is now time for me to go to hospital. Thank you.
Thank you very much, Dr. Oweru. I think there was one comment I just wanted to give a quick response to. Oh, I've lost it. When I find it, we'll give a quick comment. Thank you very much. I think we just have one last presentation that will be fairly brief. Last week, we had a number of counties presenting the status of oxygen and oxygen delivery in their counties. Because of time, we had to leave some out, and we have with us Dr. Neto. So Dr. Neto, kindly go ahead, let us know what you have and any questions or areas of support that you may need.
Yes, good morning once again.
Morning, Dr. Neto. Go ahead.
Hope you can see my slides, huh?
Yes, you can put on slideshow, please.
Thank you. And let me do this again. It was hanging.
Is it still hanging? Are you able to proceed?
Are you seeing my slide?
Yes, we are.
Is it on
you can
slide?
Go ahead. It's not on slideshow, but go ahead.
Okay.
Okay, Dr. Neto, maybe as you're trying to sort it out, I can ask a question to one of our panelists. So maybe I'll ask this to Dr. Mugera. Last week, someone asked this question as well, and I'm just hoping we can look at it again. We can just think about it again. Dr. Mugera, Dr. Kioma, either of you could respond to this. Some people are struggling with early mortalities soon after intubation. So the question is, what can people do to reduce these mortalities that occur early after intubation? Is it things around when to intubate, how to intubate, what they do around the peri-intubation period? Dr. Mugera or Dr. Kioma?
Dr. Mugera here. So intubation, we've noted in our facility, is actually the riskiest procedure. And there is a lot of mortality. One, I think, is definitely to identify your patient when they arrive and what exactly, already to categorize your patient. Do they need intubation at that point, or do they not need intubation? That's based on the clinical signs of their respiratory rate. Of course, their oxygen, preferably a blood gas, but even their pulse oximeter, and generally the patient. Remember, numbers are great, but your patient is priority. So even if you're doing a saturation of 90%, but the respiratory rate is 50, that patient needs to be escalated to the next level. They do desaturate very, very quickly. So intubation should be the quickest possible time to do that. So the expert, the most experienced person who is available at that time is the best person to do it, okay? A lot of us can intubate. Anesthetists are usually, they do that every day. So they're usually the best people to intubate, and they intubate really quickly compared to some of us who are physicians. So if we are able to already have teams who have anesthetists on those teams, so that we can call them quickly, so that they can help us intubate at the fastest opportunity in the quickest format. Some of them even intubate without even sedating their patients. That's how quick they can intubate. So that, I think those are the things. First, categorize your patient properly. So we should probably protocolize our patients. We should have protocols of patients with mild disease, moderate disease, severe disease, and critical disease. And we should know, we should have guidelines of when we are moving, when we are escalating from one device to the next device. And this will vary from facility to facility. Thank you.
Thank you very much, Dr. Mugera. So maybe for Dr. Kioma, you'd mentioned something about the routine use of prokinetic drugs, sometimes in the patients who are intubated. And Dr. Yosa is asking, what's your comment on prokinetic drugs and the risk of sudden death in COVID-19 patients? Have you observed anything like that? Is there a known association?
Thank you, Royce. Is the question about association between prokinetics and sudden death?
So it says, please comment on use of prokinetic drugs and risk of sudden death in COVID-19 patients.
Okay. I hope the question was not the association between the two, because I do not know of any association between prokinetics and sudden death. Prokinetics are good because your patients are likely to be mobile and they very likely are likely to get constipated. And remember, constipation by itself worsens respiratory outcomes. That is a known fact. Whether it is for ventilated patients or patients on NIV, on a non-rebreather mask, if they get constipated, they are likely to be more distressed. Having said that, sudden death with COVID patients is a known phenomenon, and there are several possible explanations. One, it could be respiratory related, and with respiratory, it could be severe hypoxia, because patients tend to compensate for hypoxia up to a particular level where they cannot compensate anymore, and they're likely to suddenly die from severe hypoxia. Of course, if your brain and heart are not well oxygenated, then you can easily just collapse. The second one is, of course, pulmonary emboli. And we know it's not an unusual phenomenon. If you get a massive emboli, then sudden death is likely from that. Then the third is related to the brain and either CVAs or infants.
I don't know what's going on, man. I've just sent you the email.
Sorry, Dr. Neto, please mute.
Okay.
Sorry, Dr. Kioma, please go on.
Yes, so I was talking about central nervous events, especially CVAs of either bleed or infective type that are common with either COVID per se or related to anticoagulation, especially if patients are over anticoagulated. So sudden deaths are common. In relation to intubation, which Dr. Mugera mentioned, I think I need to re-emphasize the need for proper patient assessment, and the need for mechanical intubation can be informed by criteria that are set out by various authorities, including the ARDS management protocols. But of course, you have to modify these criteria for COVID patients. And for me, patients who do well with intubation are those who are suddenly deteriorating, most of the time due to other factors. For example, PE is one of them. If a patient gets PE, put them on a ventilator, then they are very likely to survive that. Then survival of a ventilator depends a lot on the care of that patient during the ICU admission. And the most worrying thing for me is nosocomial infections, secondary infections related to ventilation. And there's a big correlation between severity or CT scan severity scores and the occurrence of nosocomial infections. You can imagine a patient who has 80–90% lung involvement with a pneumonia and gets intubated, the risk of getting a secondary bacterial infection are very high. And that's what really kills patients who are on mechanical ventilation. So also having a good way of monitoring and treating those infections is going to save lives. Thank you.
Thank you so much for that presentation. We'll just have a quick presentation from Dr. Neto, then we'll address a couple more questions before we close. Dr. Neto, karibu.
Okay, thank you very much. I'm Neto Bala from Jaramogi Oginga Odinga Teaching and Referral Hospital in Kisumu. I'll be doing a presentation on our oxygen situation. Now, in Jaramogi, we have 3 oxygen sources. We have liquid oxygen, cylinders, and a plant which was recently installed. What we are seeing there is our oxygen plant. Has a capacity of 500 liters per minute. It was installed, and we started using it the last week of last month, and so far so good. It is supplying the facility. It also has the ability of filling oxygen cylinders, about 12 to 15 cylinders per day. And there's a plan that the county is having to purchase about 600 cylinders of oxygen to distribute to the various sub-county hospitals, so that at least in case of a surge, we'll be able to recruit more facilities to help in taking care of patients. This is our liquid oxygen that is there, that is currently supplying the isolation ward. Has a capacity of 6,000 kilograms. This is a slide which I believe has been presented here enough times. We have the various delivery systems from between 1 to 15 liters, where we use the nasal prongs, simple face masks, and the non-rebreather masks. Then for the high flow, the ones who require very high flow, we have the high flow nasal cannula. This equipment was actually donated to us last year. But one of the challenges has been getting the supplies, because again, with this equipment, some of these supplies are not really compatible. So the same supplier who supplied them is the one who have to supply us, and sometimes they are out of stock. So we may get challenges here and there with that. On the left side there, we can see a twin flow meter, something which we realize is quite useful in terms of expanding the bed capacity. Because if you have one oxygen point, then with a twin flow, we're able to serve 2 patients. So that again has also enabled us to take care of more patients within our limited isolation capacity. Then for those who require higher, stepping up of, oxygen therapy, we have the option of using the NIV mask through the CPAP mode from the ventilator. Currently, we have about 3 ventilators which are functioning, and we have just received 2 more, which are being set up currently. Now for the NIV mask, what I can say is that we have the total face mask and the full face mask. The total face mask, patients are a bit more uncomfortable with it. So the full face mask, one which we mainly use. Then for the oxygen monitoring, as has been mentioned before, we have the various oxygen monitors for the SpO2s, and of course the various targets that we've been going through. We try as much as possible to adhere to them. Then for the BGS, that is for patients who require higher oxygen demand, and of course, as we are stepping up either to higher flows or NIV, we have to do the BGS, and these parameters have been of use to help in either stepping up or stepping down. Now I'll finish with the last slide on staffing. There's a list here of staffs that we actually work with, ranging from physicians and anesthesiologists, and the other medical specialists like the gynae team, surgery. We also have clinical pharmacists, medical officers, clinical officers. We also have a huge number of nurses, lab techs, records, nutritionists, psychosocial counselors, and even patient attendants. These are teams that is actually required for optimal management of our patients, because things like feeding. Of course, we need patient attendants. Those patients who have issues with removing the NIV mask and the various oxygen delivery devices. We have the psychosocial counselors to talk to them. So these are teams that have really been useful in our setting to help us in taking care of our patients. Otherwise, thank you very much.
Thank you very much, Dr. Neto, for that presentation. I think it's very encouraging to see that you have quite a good capacity. So maybe just one question. At any one time, how many critically ill patients are you able to take care of? Fully with staff, with oxygen and everything else that you need?
Well, let me talk of currently, but as we speak, we have about 7 cases in our ward, and one is critically ill. So at any one given time, I think the maximum we had at some point when we had the surge was 15. We had a capacity of 15 beds for the critically ill patients.
Wow.
But currently we have now scaled it down because of the numbers.
That is quite impressive in terms of capacity. And it's excellent because at the beginning of the last wave, you were struggling a bit with bed numbers, but we are happy to see the improvement. So I think there are just 2 last questions and we finish. So one is someone asked about anticoagulation and steroid use for patients on oxygen at home. So remember, there are 2 categories of patients, and I'll talk to those. There's a patient who has been diagnosed with COVID, is severely ill, hence the requirement for oxygen, and for whatever reason, the decision of home care has been made. Remember all the reasons that Dr. Oweru had highlighted. So this is a newly diagnosed patient in whom, because they're severely ill and requiring oxygen, they need to be on a steroid, dexamethasone at 6 milligrams for up to 10 days. It could stop sooner if the patient is well. And if this patient is severely ill in bed on oxygen, they should be on prophylactic anticoagulation. So that's one category. There's other patient who's been in hospital for a while and has been discharged to continue with oxygen at home. We do not have any evidence to extend the steroid use beyond the 10 days. So if that patient has already had their 10 days of steroids, then we're not really looking to discharging them on steroids. So that's one. The issue of discharge on anticoagulation is an interesting one. We don't have evidence to support discharge on anticoagulation. Having said that, however, there's some situations where you have to look at a case-by-case basis. So if you have a patient who has multiple risk factors for clotting and is unable to move, this is not a patient who will be up and about once they get at home. They continue to be bedridden, they continue to be very sick. Then those are situations where you really weigh the benefit versus the risk, remembering that all medicines we prescribe to patients are not without risk. So with anticoagulation, you're looking at risk of bleeding. With longer-term steroids, you're looking at the risks of myopathies, you're looking at the risks of diabetes and of increased infection. So you have to think about those. One last question. Someone is asking, SIMV, BiPAP, how do you decide which mode to use for your patients? I think this is specifically for patients who are ventilated. You go to the ICU and they say this one is on BiPAP, this one is on pressure support, this one is on volume support, this is on both pressure and volume. How do they decide which one? I don't know who will take that. Dr. Mugera, Dr. Okioma.
Let me try. It's not a one-touch question to answer. You really need to understand the principles or the basic principles of mechanical ventilation to determine which mode you're going to put your patient on. There are those mandatory modes. There are those other modes that are more permissive to patient-initiated breaths. And there are even more advanced modes we call intelligent that are able to adjust after analyzing information that the ventilator is able to gather from the patient. So the first thing is, one, you need to understand your patient's lung mechanics, and that you can do immediately after intubation. You can try your patients on different modes to see which one suits them best. And then if you are weaning your patient, then you can opt for other modes that of course allow the patient to breathe more as they transition to being extubated. Having said that, generally, in my opinion, patients with COVID, because of the lung stiffness, they tend to do well with pressure modes as compared to volume modes. With volume modes, you get very high peak pressures, and in most cases, you actually end up having cardiovascular instability from that. It is not a one-off, and it's something that the anesthesiologists and other critical care people are able to determine having, of course, evaluated the patient's lung mechanics. Maybe Dr. Mugera can add.
Can you hear me?
Yes, Doc.
Hello? Yeah,
We
so
can hear you.
I totally agree. It's difficult to choose one mode for every patient. So every patient is unique, and it depends on how much support you need to give them and how much they are also able to do their own support. So if they're on full support, then is what we choose mandatory modes. If they have some sort of their own breaths, but they're not adequate, that's when we do the non-mandatory modes. But it's exactly as Dr. Okioma said, it's dependent on the patient. And yes, for COVID, we are seeing pressure supports or rather modes that deliver pressure rather than volume are doing better for our patients.
Thank you very much. Thank you, Dr. Kioma, Dr. Aweru, Dr. Mugera. We've had an excellent 5 weeks looking at issues around oxygen therapy. And I think everybody will agree with me that we have learned a lot. And I hope we are taking all these things back to our facilities and improving care of our patients with severe and critical illness. I think it's been very excellent. Speaking for myself, I've learned a lot, and it's been an excellent 5 weeks. The panelists who are here, please unmute and clap for our 3 experts who are very taken us through the last few weeks. Okay. Myself. Thank you very much. We're now just coming to the end. There's some quick questions that you can just give a one-word answer. So one, pregnant and lactating women, should they be vaccinated? The answer is yes. Okay. The issue of okay, there's one other one that came up that I'm trying to find. That is so lactating mothers, yes, give them the vaccine. People have asked about the guideline, and we've talked about the guideline that was being developed. This is ready and should be out by next week. So be on the lookout. The guideline will be coming your way by next week. We'll share it through all platforms so that everybody has it available, and share with as many people as you can. So I think with that, Surendra, is there something else? Okay, with that, we come to the end of this series for oxygen. Soon we will be looking at issues around pregnancy. And I know there was one question asked about pregnant women. We sort of commented about it last week. If you have a pregnant woman who you are struggling to ventilate, you need probably to deliver that woman, get an obstetrician on board, get a critical care specialist or anesthetist on board to help you, or a physician, get someone to help you manage that patient. We've noted high mortality in pregnant women, especially those who required more than a non-rebreather mask. So you really need a team on board to make quick decisions, talk to the patient, talk to the families, so that you make early decisions. But having said that, we will have a series on pregnancy and managing COVID pregnancy, and you'll be informed on when that will start. So thank you all. We've had excellent attendance, and we're very grateful for your time, and we hope that you've learned as much from us as we have from all the questions that have been asked. And we wish you a very good weekend. Thank you. Bye.